Hello, my name is Kate Barlow. I am the founder and the host for today's meeting. This is the International Interprofessional Mentorship Group. Today is October 13th, 2022. And today, Dr. Haley Matuszek will be here to talk about upper extremity limb loss, orthopedic conditions, and fall prevention. Please keep yourself on mute during the presentation, but if you would like to ask a question, please go ahead and type it in the chat box, or you can raise your hand and I'll call on you. You need to stay on the entire presentation to receive a certificate of attendance, and we will have a survey link in the chat box for you to complete to receive that certificate. At the end of the presentation, we will have question and answers, and then we'll have an informal meet and greet. Thank you all so much for coming today. Haley, thank you for joining us. I really appreciate you coming and sharing your expertise.
Awesome. Thank you so much for having me, Kate. I'm so excited to be joining all of you today for this International Interprofessional Mentorship meeting hosted by the American International College. For today's meeting, I will be sharing an area of practice that's near and dear to my heart, OTs role in comprehensive rehab, or what we would call here in the US, inpatient rehab. And I will be addressing the role of OTs working with upper and lower extremity limb loss, fall prevention, and orthopedic conditions. So I have included Spaulding Rehab's logo here, as this is where my area of clinical expertise stems from. This nationally ranked teaching hospital is an inpatient rehab hospital located in Boston, Massachusetts. I've treated here full-time on the comprehensive rehab unit for a little under 4 years. I've also highlighted the University of New Hampshire here, as this is where I graduated from with my master's, and it's also where I currently hold the position as academic fieldwork coordinator for the UNH OT fieldwork programs. I've maintained a per diem role at Spaulding since I have transitioned into OT academia, simply because I love clinical practice and I cannot leave it entirely. So to give you a little bit more context about where I am in the world, as everyone's from everywhere on this meeting, which is so exciting to me, I currently reside in Boston, Massachusetts, one of the most historical cities in the US. I've included this photo of the USS Constitution, or as they call her, Old Ironsides, pictured on the left. This ship was constructed in 1797, and it is the oldest commissioned warship still afloat, which is pretty cool. Pictured to the right is UNH's, or University of New Hampshire's, famous Thompson Hall, located at the center of the UNH campus in New Hampshire. And right now in New England, many trees are changing colors, which is the infamous, leaf peeping season, as we call it in New England. They've got reds, orange, yellows. It's pretty beautiful. So for today's agenda, we will cover the following: OT's general role in a comprehensive rehab unit as it fits into the continuum of care. We're going to break down OT's role, including the goals that we might see for patients with these conditions and evidence-based interventions for each of the following: lower extremity limb loss, upper extremity limb loss, orthopedic conditions, and fall prevention. So in inpatient rehab settings, we have a variety of team members, including but not limited to physicians, nurses, OTs, PTs, speech language pathologists, caseworkers, et cetera, et cetera. Based on my personal experience on the comprehensive rehab unit at Spaulding Rehab in Boston, the typical length of stay for a patient could be anywhere between 14 and 16 days. So in the US, the general course of the continuum of care pictured here on the slide is that an individual would experience an injury, they would find themselves in the hospital or an inpatient acute, where they may transition then into inpatient rehab, where I'm going to be speaking about today. And this is where they may be more medically stable, and they're able to start participating in more intense rehab. Once they leave inpatient rehab, they'll generally transition either to a step-down facility or subacute rehab, should they still require medical support or more rehab before transitioning back into the community. If they're well enough, they could go straight back to the community where they would find themselves in home health therapy. The end goal for this stage of care in inpatient rehab is to collaborate with all of those team members and address the patient's goal to promote a safer discharge back into the community. So I just wanted to preface some context before diving into this area of practice. So in the US, we use the occupational therapy practice framework, which is developed and updated by the American Occupational Therapy Association to guide our practice. This includes the OT process. So that includes the evaluations, interventions, and outcomes that we see for our patients. And when looking at the most up-to-date OTPF or occupational therapy practice framework, the common interventions primarily used in comprehensive rehab include the following that are bolded here. Therapeutic use of occupations and activities, where we highly focus on increasing functional independence through use of activities of daily living. Interventions to support occupations, which may include therapeutic exercise or simulated therapeutic activities. Education and training, which is in everything we do, and promoting self-advocacy for our patients. So we're going to dive right in. Treating individuals with limb loss. So upper or lower extremity limb loss. I figured we should start here by discussing, first and foremost, that the perspective we would take with all of our clients and patients is it is important to approach them with a holistic approach. We should not only consider their physical injury and the loss of their limb, but also their mental, emotional, spiritual, and social needs. So building rapport with your patient, just like you would with any patient, is extremely important in identifying what's important to them and taking those first steps during the evaluation and then intervention process. And every individual's goals may differ as to what's important to them in helping you shape their plan of care. So psychological issues frequently seen in the amputee population include fear of the unknown, what comes next, loss of self-esteem as they've lost a part of them, a part of their body, loss of self-confidence subsequently, fear of rejection from others, and loss of occupational roles. So those are pretty heavy things to address. Even though we're looking at somebody from the physical side of things, we also need to acknowledge all of these feelings of loss that a patient may be experiencing. Peer visitors can be invaluable to this adjustment after limb loss. So a peer visitor would be someone who has experienced this before. If you have a patient that has transhumeral right upper extremity limb loss, if you have someone else that has also experienced this, they would be a peer visitor. They've already gone through this whole phase, this whole process, the recovery process, and everything that goes with it. From my own personal experience, peer visitors are often even introduced before surgery even occurs, so that patients have an established relationship with someone who has been through the experience before. I often use what I have linked here, and I have links throughout this presentation to various websites and resources. The National Amputee Coalition is phenomenal. I've often used it with my patients for upper and lower extremity limb loss. It has so many resources, so many supports. Individuals can be connected with other peer supporters through this site as well. So you could have a patient that has a very specific limb loss. Maybe it's a shoulder disarticulation, and you may not know anyone that previous patients or people who are involved in your community who have also experienced that. But if a patient goes onto this website and searches that limb loss, they could be connected with somebody that they could connect with virtually, which is phenomenal. I've also included the global resources page that the National Amputee Coalition has compiled as well, which has an abundance of resources that I cannot speak enough to. So I'm going to first dive into lower extremity limb loss because my clinical expertise, I've seen more patients with lower extremity limb loss than upper, and many of the interventions do overlap. So when working with a patient with lower extremity limb loss or an amputee, often their primary goal as soon as they meet you is to get their prosthesis and walk again. That's their goal. However, I have learned that this is not everyone's goal. Some patients have had a very long, complicated medical history, hospital course. They may simply be focused on proper wound healing and successful wound healing, and just getting themselves safely home at wheelchair level. When wheelchair use is maybe more of their goal, this may be more practical for some patients, given the nature of their limb loss. So was it vascular related, as many are? What are their weight-bearing concerns? Do they have non-healing wounds or ulcers on their contralateral foot, other comorbidities, or simply even their age? It's important to remember that some patients' short-term goals are different than their long-term goals. So they may simply be thinking, I just want to get home in my wheelchair first. I will think about getting a prosthesis later. OT's primary goals, as they are for many of our patients in this level of care, is to increase their independence and safety with transfers and ADLs, and start educating them about managing their residual limb. So to highlight the interventions from the OTPF again, listed here are the primary interventions OTs would focus on for lower extremity amputees. These range from adapting ADLs to education around edema management and the next phases of the rehab process. I will go into more depth for each subsequent intervention. One note, for purposes of today's presentation, I will be highlighting above knee and below knee amputations more than these others listed here on this photo. So all members of the interprofessional team reiterate the care of the residual limb. It is so important. Occupational therapy really does incorporate this education and training throughout all of our sessions. Edema management is a priority post-amputation and initially begins with the use of figure 8 ACE wrapping, shown here on this picture with the many steps. Amazing drawing. I wish I could draw. And after patients' wounds heal, their sutures and staples will be removed, and they will transition to a shrinker sock as another form of compression, shown in the second picture. Shrinker socks are made of specialty material specifically designed to create more pressure at the distal end of the limb, to create that nice shape for the residual limb for when they're placed in their prosthesis. So as you can see, without the shrinker sock, the distal part of that limb is wider, but with the shrinker sock, it starts becoming more of this cone-like shape. That's what we're aiming for. The purpose of ACE wrapping is not only to control the edema, but it really is a lot of shaping your limb for future prosthetic use. I have included here, I almost went to the next slide, 2 links. They are my favorite videos of above knee residual limb ACE wrapping and below knee residual limb ACE wrapping. Just very easy to follow of a physical therapy student completing this. They're both linked to YouTube here. Here is myself from an assignment that I had done in school, also on residual limb ACE wrapping. And I've taken the time to also show you how you could use a rolled up towel as a way to practice this. It's definitely a skill that takes some practice yourself before you train someone else to do it. So I hope that this additional video is helpful should you need to practice this skill a little bit more. Hi, everyone. And that's my voice. So to break down a couple more interventions for our amputee population, desensitization is another high priority. It is able to assist patients with hypersensitive residual limbs, which is very common. So using techniques such as massaging your distal end of your limb, tapping, or using various textures such as a cotton ball or a sock, or really anything that a patient can start to tolerate, and building on that can help calm down the severed nerve endings that have subsequently been lost due to this amputation, that are giving that phantom limb pain that many amputees suffer from. It is crucial to educate patients on self-massage and the carryover of that technique, because this will be something that they will likely do as they transition out of comprehensive or inpatient rehab. Skin inspection is another intervention that we address with patients with limb loss. OTs educate assessment of the residual limb for proper wound healing. So as I've shown here, this is a flexible mirror, which I've even tried to make myself through, we're always trying to make things, right? For patients to be able to see the underside of their limb if they're not able to, flexibly have the range of motion to see it themselves. And it's also really important to assess their contralateral foot. So for our diabetic patients or patients with, poor vascular, related diseases, it's really important that we're being preventative by also educating patients to watch out for any skin changes, ulcers, etc., on that contralateral foot, because they may not feel it, right, due to neuropathy or other comorbidities. So 50%, this was a pretty wild thing I found. There's a 50% increase of incidence of contralateral amputation within 4 years after the primary amputation. So really, using our knowledge about this to promote prevention is really important. Positioning is also an intervention that is constantly incorporated into OT sessions. The most common contracture seen for a below knee amputation is that knee flexion contracture, basically as pictured here with the tapping of a residual limb. So I'm going to show you on the next slide. There's some tips and tricks to prevent that knee flexion contracture from forming. So this would include avoid placing a pillow underneath the knee. That's going to only encourage that knee bending at the joint. Utilizing a leg rest when you have a patient in a wheelchair so that their knee continues to be an extension is also really important. That elevation can help a lot with edema management as well. For above knees, it's really important that we start getting our patients in prone on their belly so that they can get a really nice hip flexor stretch as pictured here. Because if you think about it and you're sitting up in a chair for a long time or sitting in bed, that hip flexor is just shortening essentially. It's not having the opportunity to lengthen and be stretched post amputation. In prone, I found that I'll have my patients also engage in upper extremity or upper back exercises. So it's kind of a twofer there. So as we transition to upper extremity limb loss, you will see many of these interventions that are priorities for our lower extremity limb loss patients. They're also priorities here with this population. For purposes of today, I'll be focusing on transradial and transhumeral amputations. The following interventions have similar purpose to that of the lower extremity interventions. So we really do focus on edema management to not only reduce edema post-amputation, post-surgery, but to shape the limb for future prosthetic use in the same nature that we are aiming for this cone-like shape or narrowing at the distal part of the limb. We're going for the same idea with our upper extremity patients. Scar management is another important intervention for upper extremity amputees. So scar management, as we know, consists of remodeling or realigning collagen fibers and it can overall assist not only with decreased, scar development, but overall cosmetic appearance. So a big thing that we know as occupational therapists and individuals is that your upper extremity, your hands, are one of the things that people see the most, right? Even as I'm sitting here on this camera, you see my face and you see my hands, right? Those are the things that are seen the most. So for upper extremity patients who may be transradial or transhumeral, we really want to, promote scar management and wound healing as much as we can to limit that unfortunately that stigma that occurs. So, try and have the best cosmetic appearance that we can, because not all of our patients may become prosthetic users depending on what level they are and what choices they make going down their plan of care. So for those individuals who suffer from upper extremity limb loss due to burns, especially, silicone can be used to assist with scar management as well. So silicone, I had no idea, but it can decrease nociceptor activity and decrease neurogenic inflammation to reduce scar tissue. So they will sell, you can find it online, silicone patches. I'm happy to send a link. I don't know if I included it, that you can place on your patient, where their scars may be forming, especially if they have a burn-related injury there as well. And you can even put another piece of compression over that, whether it's an ACE wrap, or in the US, we often use Tubi Grip to provide additional compression, and it will do wonders for that scar. And it's something that's easy to apply. Patients often will just even wear it at nighttime and then take a break in the morning for their skin to breathe. Positioning in the same regard to lower extremity amputations is important to prevent contractures. So elevation of that limb, not only helping with edema management, but also promoting, some abduction or flexion away from the body, so that patient's not getting tight and guarded closer to the proximal part of their body. I've also heard from patients, just in experience, that, having a specific position or elevation can be really helpful with pain sometimes. So, there's many things that you're addressing by promoting positioning. I have included 2 photos here of transhumeral and transradial ACE wrapping. I will say there's many different ways to do it. I tried really hard to find a video of this. I was unsuccessful, but essentially the idea, in the same way that you'll see in my video for lower extremity limb ACE wrapping that I included, you want it to be tighter and more compressed towards the distal end and looser towards the top. So really paying attention to that tension that you're providing. And you also want to avoid going around circularly to create more of that tourniquet. You really want to avoid that. That's why we do the figure 8 ACE wrapping, so that we're being more mindful about where we're providing the compression, so that we're not cutting off circulation. So I'm not going to read everything on this slide, but maintaining range of motion and strengthening are also really important interventions for not only this population, but our lower extremity amputees as well, although our PT counterparts often take over that role in our lower extremity amputees. So you can find ways to integrate these into every session. You're going to want to work with the physician or surgeon to determine when more areas of range of motion and strengthening can start to occur. Generally, people will want range of motion to happen right away. We don't want patients to get stiff and stuck in one position. It's not going to help them with their overall function and independence, but also future prosthetic use. And I've included some examples in later slides, but even incorporating scapular strengthening, if that patient is unable to really move that arm right away, the swelling may be limiting them, or pain is too much, maintaining any upper back or scap strengthening is really important. or even starting with isometrics. So I've seen patients, once they can with weight bearing, using a wall or something aside from them to participate in some isometric can be really helpful. And I found, as I was just, getting ready for this presentation, that really using a mirror for some visual feedback can be really helpful with this population too, as they start to do more range of motion, because they might not have an idea of, matching each side. I really like to point out adaptations on this slide. This is where I think our expertise as OTs comes into play with all of our patients, but especially this population. I often find myself referring to the PEO, or person, environment, occupation model when considering how to adapt tasks for this population. So, as soon as you see this patient, they're not going to be jumping straight to get their prosthesis. They have to go through the wound healing phase. Everything needs to, resolve itself before they even start to take those steps and get fit. So a lot of what we're teaching them is how to do things one-handed. I have so many resources at the end of this presentation about how to dress one-handed, how to put your hair up with one hand, how to cook with one hand. And it is remarkable to me how patients start to figure this out, just that neuroplasticity of our brain, even into adulthood. And just thinking about how you can approach a task differently using the environment, using the way that you look at the occupation, what can you change about it is just remarkable. So always remember, you can go back to the basics and use a model like PEO to guide your thinking. The second patient population I'll be addressing today is individuals with orthopedic conditions. So included here are many of the interventions we touch upon as occupational therapists with all populations, but I'm going to highlight the following. So using simulated environments and routines to engage in ADLs, IEDLs, or instrumental activities of daily living, and functional transfers, therapeutic exercise, training with assistive devices, and energy conservation methods. I'd also like to point out here that I've highlighted 3 conditions that I've seen a lot of, which are spinal laminectomies, include spinal fusions, spinal decompression surgeries, hip fractures, and multi-traumas as a result of a car accident, for example, involving multiple fractures. So when it comes to orthopedic conditions, there are typically some form of surgical or weight-bearing precautions associated that we have to account for as OTs. So it's crucial when planning out a safe transfer or how to set up an ADL routine that we consider any and all of those precautions. Engaging in simulated environments as much as possible, from my own experience, has been extremely helpful when problem solving through how to do something safely, considering all these precautions. And most importantly, it helps the patient, caregiver, family member to transfer those skills and knowledge at discharge. Deconditioning is a major side effect of prolonged hospitalization, as we know, simply given the nature of being in a hospital bed for a prolonged period of time. So in inpatient rehab, this is perhaps the first opportunity that a patient has to build up their tolerance of being out of bed, sitting upright, never mind getting up and trying to walk around. I think demonstrating our unique role to the team, this is an opportunity to shine using meaningful occupations to incorporate into sessions, such as engaging in a game of toss with a ball with a family member, getting that patient to start sitting or standing out of bed. Many of our patients will require use of adaptive equipment. So that could be a shoehorn, a sock aid, or specialty DME, such as a special tub transfer bench, which we use pretty frequently here in the US as they recover from injuries or surgeries. It is important that we take the time to provide many different opportunities for learning and how we train patients and caregivers to use these items so that we promote carryover for patients and families. I've included a video at the end of this presentation of using some of that equipment to dress. So activity pacing and training, as well as education. It's an effective intervention for non-surgical lower extremity musculoskeletal disorders. But I also found in this article that multidisciplinary approach to this is just, it's effective no matter what. So I think the idea that I took away from this brief article that I found is that really, yes, we're addressing activity tolerance by getting patients out of bed, doing their ADLs, getting to the bathroom, whatever it is to get them safely home. But we're all doing it. The physical therapist is doing it. The nurse is doing it. So having that multidisciplinary approach is really key here too, and carrying over education. The third and final area I'm going to address today is fall prevention. So for my doctoral work, I really highlighted this and tried to expand on OT's role in fall prevention in the inpatient rehab or comprehensive rehab unit, and especially thinking about fall prevention at discharge back into the community. In the US, we're really lacking here. And it's just something that I've fallen in love with as I've learned more about it. So our role is many. We address the home environment when thinking about falls and a patient returning home. We're addressing their roles and their routines. So where are they going to find themselves at home? How is that going to impact their fall risk? We will provide education to the patients and caregivers if they have them at home with them about their fall risks and their self-awareness around that, how to combat that and prevent them from happening, and barriers that I have found in the inpatient setting are time. We don't have enough time to really address this because we are moving patients through as quickly as we can to open up the next bed for the next patient that needs it. The complexity of our patients. So as you can see, I've just dived into 3-4 different patient populations. They all have different needs. They all have different fall risks that are associated with those needs and the priorities surrounding their discharge goals. So, the goal might just be, can they be safe enough at home for the daytime? Great. Well, what does that really look like? So I've had many conversations with my own team members about this, and there's a lot of work to still be done. So gaps in interprofessional fall prevention care is one area I'd really like to highlight here. This is a team effort. We cannot have just one of us, just the OT addressing falls, just the nurse addressing falls. It's not going to be effective. In the inpatient rehab setting, we have many ways that we prevent falls, including bed alarms, chair alarms, identifying patients simply, as you can see from this photo, with a bracelet that they are a fall risk, so that if a nurse walks in to assist a patient that they may not be familiar with, they quickly see that they are a fall risk. So they are on high alert if they're trying to help that patient move or get up. So what I found, and also from the research, is that when roles and responsibilities are not clearly laid out, ambivalent attitudes among team members may develop, and furthermore, leading to potential gaps in patient caregiver education may occur from this. So the idea that if we're not clear about who's addressing what, well, then I'm not going to do it, right? If we don't know who's doing what and whose role and responsibility is what, it's maybe not going to happen, or there's going to be an unclear message we're giving to a patient. Patient-provider dialogues were seen to rarely occur during the high-risk transition home after discharge. So, a physician may be addressing their medications and everything else related to their discharge, but it was shown that they maybe weren't addressing their falls or their fall risks upon discharge. And in the US, the physician is often our leader on the team. So if they're missing this conversation or they're not highlighting it, it may not seem as much of a priority to a patient at discharge. older adult patients reported decreased knowledge about fall prevention strategies at discharge. So that really just highlights right there that we're not giving them the resources and the education they might need before they go home, therefore not assisting them with their overall fall risk at home. And as you can imagine, a patient who's just suffered a car accident and has multiple injuries and weight-bearing issues, if they're not clear about what their current fall risks look like, they might just think, oh, I can go back to doing everything I was doing at home if that's not clearly laid out for them. Additionally, a lower extremity amputee, I say to every patient I've ever had, you're inherently a higher fall risk than you were before because you do not have another point of contact, on base of support. Your whole center of gravity has changed. Even once if they become a prosthetic user, it is a different nature of life. I've had many patients say they will roll out of bed and get up to go to the bathroom in the middle of the night, and they think that their leg is still there, and that could be even years down the road. So their fall risk inherently increases. Lack of ownership and complacency are other areas that I found in addressing fall prevention as an interprofessional team, and overall lack of knowledge surrounding evidence-based fall prevention programs. So a team member maybe not feeling confident to discuss this if they don't feel like they have the evidence to support it. In the US, we have many fall prevention programs that are often used at the community level or outpatient, but we don't have many that highlight this transition for our high-risk patients. Just want to make sure that wasn't a question. Okay. So to combat these barriers, which I just listed so many, how do we do it? I've found that even among my own team of clinicians, my physical therapy partner, nurse, physician that I work with closely, we found if we can identify that our shared patient is a high fall risk at discharge, especially at discharge, we try to each express our own role and how we plan to educate them in their family. For example, if it's medication related, a side effect of a medication that may increase their fall risks, such as orthostatic hypotension, where then the physician and the nurse may combat that and address that with the patient. This takes more time and coordination among the team. However, from my own personal experience, I've seen that it works just by setting out those roles and responsibilities from the get-go. So this is one strategy that's worked for me. In the research, I found that 83% of hospitals in the US utilize this interdisciplinary falls education. But it really made me wonder, is that just happening in the hospital and not as much at discharge, where, that's when we see patients go home, fall, and potentially return to the hospital for another injury. So more of the research and informing the delivery of fall prevention education. I found that when we provide education in multiple different ways, so via video, audio, written materials, experiential learning, so getting someone up and moving, that's more effective than just providing a written handout to a patient or a family member. Using this combination of modalities can be more effective than one single form, and consideration of individual fall risk factors, the environment, should be factored into design and delivery of education. So thinking about simulated environments when we're practicing things. Additionally, active learning can be extremely useful, and theories of behavior change using like educational principles to guide that can be helpful in fall prevention too. So it's a lot there, but the idea being we need patients to have buy-in. We need them to be active learners in the process. We need them to be motivated to participate. If they're not, the learning's not going to happen, and the carryover is not going to happen at discharge. So engaging your patients as much as you can to understand their fall risks if possible, if they're cognitively aware and intact, and if not, getting the buy-in of a caregiver can be really helpful. So, interventions to address fall prevention. Education to promote self-awareness around falls and fall risks, from my own experience, has been really helpful with patients after they experience an injury or after they have a surgery. I've included 3 resources here that are available in English and Spanish. There may be other languages out there, but these were from the National Council on Aging. These include the Falls Free Checkup, which is, I believe it's 10 questions for a patient to take about their own individual fall risk, myths and facts about falls. So many patients, as they get older, may have one perception of falls and fear of falling. However, many of them are myths. So this is a great educational tool to sit down with patients and explain. And lastly, a conversation guide for caregivers. So having a caregiver come to you saying, I know that my parent is now an increased fall risk after this surgery, but they won't listen to me, or they're not interested in solving this before they go home. Using this guide can be really helpful to give the caregiver some education as well. So, what has been effective in my own personal experience in practice? Simulated fall recovery. So literally putting our patients, if safe, literally putting them on the ground in a safe manner on a mat, and walking through the best and safest way for them to recover from that fall. If they're not able to recover from the fall by themselves, I will walk through with them what they should do to make sure that they're safe before they call for help. Tips and tricks I've given patients may be just to try to scoot back so that their back is up against a chair or the wall so that they're supported at least in a sitting position. Carrying around a device with them. So if they have a mobile cell phone, can they carry it with them? So in the event that they're alone and they fall, at least it's near them. I have heard one too many patients tell me I fell and I had to crawl or drag myself to get to a phone or get to call to help. So if they're able to have it on them, that's invaluable. Yes, sometimes people will say that's the PT's job. The PT should put them on the floor and do that. Well, I argue, I think we play a role in that too. I think that's invaluable to go through that process and experience and teaching someone how to safely get up, given their precautions, given their weight-bearing status, given their new perhaps physical limitation. So I think we play a role there too. Simulated home environment to perform ADLs and IADLs. So putting someone in the simulated environment as much as you can to identify obstacles, barriers, ways that they could simplify how to do something so they prevent their chances of fall risks has been really helpful in my opinion for a patient to also see and identify a potential fall risk. Educating on the use of activity analysis to break down tasks. So looking at an activity and everything that's involved in it, and then teaching patients how to do that. So if they see, well, I want to go cook my meal for dinner, these are all the steps I need. These are all the tools I need. How can I simplify this for myself so that I'm less at risk of tiring myself out? And I know that if I'm tired, that increases my fall risk, right? So teaching them how to do those steps themselves. Again, as you can see from all that I've listed here, we want to make our patients have buy-in and we want them to feel empowered when they leave. Fear of falling is a huge thing. And yes, there's such thing as having a little anxiety over falling, but we don't want our patients to be so fearful that they don't engage in any occupations at all. That's only going to limit them even more. So overall key takeaways from OT's role in a comprehensive inpatient rehab unit. Always consider the patient's end goal. We do this already as OTs, but every person's different. Where they might see themselves next in their next phase of recovery may be different than what you hope for them or what you're thinking for them. So make sure you are on the same page. Educate your patient, caregiver, their family members as much as possible before discharge, especially thinking about their fall risks, their, what has changed now, what's new, right? Maintaining a holistic point of view. Don't forget about patients' psychosocial needs, especially when looking at our amputee population. Collaborate with your team members. It's important to not only analyze all different perspectives and who's approaching what aspect of care, but demonstrate your own value to the team, right? Where I think we're always trying to remind ourselves, wait, that's my scope of practice. I can do that, right? Make sure you're expressing that to your team members. And lastly, and the thing I struggle with a lot in this area of practice is trying to be as occupation-based as possible in inpatient rehab. It's really easy to go down a path of doing a lot of exercises or just, how do I get to the next patient, the next thing, right? How can we get occupations in there, right? Can we put somebody in a situation that they're going to be more motivated, find something more meaningful, whether that's cooking or playing a game that they're interested in, or getting back to a role that's important to them. I think always strive for that whenever you can. So thank you so much for having me. I know this was so much information that I tried to cram into about 45 minutes. But this is my contact information here. I would love to connect with any and all of you despite our time differences moving forward. And in these last few slides, I have included many resources as well as one I'm going to have Kate send along in a document or PDF form. So thank you so much.
Thank you so much, Haley. This was great. And for everyone who has joined our group email, I will send out a copy of the slides, as Haley said, with the recording. Does anyone have any questions? You can either type it in the chat box or you can raise your hand or just take yourself off mute. Well, I'll go ahead and stop the recording while you all are thinking of your questions.